Going to excellent, and I'm going to take Jim off hold. Good afternoon, everyone, and welcome to the Emory Living with MCI Dementia lecture series. We are so appreciative that you've taken time out of your day to join us, and we have an exceptional speaker today. My name is Debbie Arnold. I am one of the social workers on the cognitive neurology team. I am joined by Ashley Varner and Alice Cooper Salisbury, two of the other licensed clinical social workers here. And a couple of housekeeping items. Because this is a webinar, chat will be disabled, but we do want to encourage everyone to participate. If you have questions or comments, please do use the Q&A feature, and you don't need to wait until the end of our talk. You can ask questions when they occur to you, and we'll ask our speaker to address them at the end of our program. We try to present on topics that we know are of interest to the patients and families of cognitive neurology, the questions that we hear as frequently asked. But if there are topics or questions that you want to suggest that we find as excellent speaker to present, please do let us know, because we're always open to suggestions from our community. And without further ado, I'm going to ask Alice to please introduce our speaker.
Good afternoon, everyone. I have the pleasure of introducing Dr. James Law, who is the Vice Chair of Neurology of Emory University. He is also an Associate Professor of Neurology in the Neurology Department at Emory, and he's the Allison Roy Richards Chair of Neurology at Emory University. He is also one of the most all-time favorite neurologists in our Emory Cognitive Neurology Clinic. He brings his wealth of knowledge, his research, his experience, but also his humor and bedside manner to our clinic. And we are all grateful to be working with him, and we are so excited to hear him speak today. He is going to be talking about MCI and dementia, just an overview of them, and also some of the treatment options and drugs that are happening, that are exciting and happening in the world of Alzheimer's and dementia. Well, excuse me, in the world of MCI and dementia today. So we want to welcome everybody, and welcome Dr. Law.
Thank you, Alice, and thank you, Debbie and Ashley, for all the wonderful work you guys do. You're just terrific, and you bring so much benefit and help with your efforts to support and educate our patients and families. So thank you very much for all that you do, including organizing this webinar series. So I am going to, Debbie and Ashley figured out together how to actually allow screen sharing and turning on videos and stuff. So, so hopefully everybody's seeing my screen okay. And I'm also going to get fancy and even turn my pointer into a laser pointer here. So I'm going to do an overview of MCI and dementia, as Alice said. And in clinic, when I'm seeing patients and discussing diagnosis, this is sort of what I see. So if I tell somebody, well, I think you have MCI, well, that doesn't sound very good. But then, and then if we start talking about dementia, yeah, that really doesn't sound good. But then as soon as I drop the A-bomb and say the word Alzheimer's, people really start to get anxious and concerned a lot of times. And so I want to just start by answering that question of what is MCI, what is dementia, and what is Alzheimer's disease. So MCI and dementia are not diseases. They're symptoms of diseases, and they can be caused by any number of different things, but they have certain things in common. In both instances, when we talk about MCI or dementia, we're talking about changes that represent a decline from what is normal for a given individual. And in both MCI and dementia, these symptoms have to be persistent, because if somebody's very sick, or somebody has exposure to medications that have side effects, those kinds of conditions can create transient confusion, and that doesn't count. That doesn't count as MCI, and that doesn't count as dementia. In MCI, oftentimes, not always, but oftentimes, the symptoms, the cognitive changes that are persistent, may be isolated to the domain of short-term memory loss, difficulty recalling things that have just happened. Whereas with dementia, usually the difficulties affect multiple areas, and this is most often picked up either by examination, but most often picked up on that fun memory testing that we do in clinic that everybody enjoys so much. But that testing is designed to explore different areas of cognitive function, including language abilities, as well as memory and executive function, attention, things like that. And so the difference with MCI and dementia is dementia tends to affect a little bit more areas. And then the severity is the main distinguishing feature. Is people with MCI are at a stage of symptoms where they're largely functioning independently. And sometimes some of our patients who are diagnosed with MCI may still be winding down their businesses or law practice or medical practice, but they're clearly declining and are having more difficulty, but still functioning largely independently. Whereas once you cross that sort of boundary line from MCI to mild dementia, there's at least some functional limitation. And then, of course, the concern is with dementing illnesses that dementia may not remain mild. It may progress to become more severe. And graphically, if we look at it like this, almost any disease that can cause cognitive decline, MCI and dementia, if they're progressive degenerative diseases, in early stages, the symptoms may be very mild, but then as symptoms worsen, there are gradually more increasing severity of symptoms. And then this is in later stages, this is where the severity of symptoms can lead to much more profound challenges and profound losses. But in early stages, in mild cognitive impairment or very mild dementia stages, people are still experiencing an excellent quality of life and functioning quite independently in many cases. So this is something, this sort of progression is something to keep in mind. And dementia from all causes is a enormous global problem. And I'm not going to have time to go into some of the details of why this may be. But as time goes on, while dementia rates are increasing everywhere, and largely driven by the fact that we're living longer, whether you live in North America or sub-Saharan Africa, life expectancy globally is increasing in almost all areas. But the rate of increase of dementia in low and middle income countries is going to increase much more rapidly, burdening countries where they're less able than we are here in the United States. But the rates are increasing everywhere. And so this represents a major challenge. Now, what's the difference between Alzheimer's and dementia? So I was talking about what MCI and dementia are. And like I said, MCI and dementia are just symptoms. So it's like saying I have a stomach ache, only, your stomach ache is in your head, I guess. But saying I have MCI or dementia is just saying I have a symptom affecting my brain. And when I have a stomach ache, this is something that's affecting my abdomen. And you might have a stomach ache because we put our damn cat on a strict diet, so he doesn't look like this anymore. But you might have a stomach ache because you ate too much, or you might have a stomach ache because you have a gastric ulcer that's eating a hole in your stomach lining. And those are both causes of stomach aches, but very different diseases. And so Alzheimer's disease is like saying I have an ulcer or I ate too much. It's the cause of MCI and dementia. And I selected this image of an ulcer because I thought some of you might want to order a tote bag with a picture of a gastric ulcer. And so you can order that from Spencer Hutton. So when we say somebody has Alzheimer's, we're talking about a very specific disease that can cause memory loss, mild cognitive impairment, and dementia. But it's not the only cause. There are other causes: vascular dementia, frontotemporal, Lewy body, something called late or hippocampal sclerosis, PD dementia, and then something that we're increasingly aware of, and that is the complexity of these diseases. So even though Alzheimer's disease is represented as this 900-pound gorilla that accounts for a large proportion of dementias, MCI and dementias, in fact, it's a lot more complicated than that because there may be overlapping pathology. So some individuals may have Alzheimer's disease plus, many individuals have Alzheimer's disease plus vascular changes or plus Lewy bodies or plus something called TDP-43. And so we're still sorting out some of the complexities of that. But each of these conditions do have characteristic features. And so we can discriminate and say this is Alzheimer's disease or this is Lewy body dementia. One of the things that we will almost always get in the course of our clinical evaluation is a scan of the brain, an MRI scan of the brain. And it's important to understand what you can and cannot see on MRI scans. So for those of you that I have seen in clinic, I might have said to you, the MRI scan just tells you how your brain looks, not how it's working. So it might be pulling a Miss California who might be drop dead gorgeous until she opens her mouth and proves she's an idiot. So your brain might look perfect, but it might not be working perfectly. And the way we assess how your brain is working is based on your symptoms and what we see on your examination and memory testing. And then conversely, your brain might have all kinds of structural abnormalities. I often think back and think of a research volunteer from many years ago, a wonderful woman who was a nurse and then taught nursing for many years. And then after she retired from nursing and teaching, she went back to her hometown, established a nonprofit, founded a homeless shelter in her hometown. And she did that work until she died. And right up until very close to her death, she was doing great cognitively. We were assessing her, and she was fine. Her brain looked terrible, but she was functioning great. So the MRI scans just tell us how your brain looks, and that's what we're looking at. We're looking to see if there's any areas of damage or anything else. The second limitation is that we can see things as small as about a 0.5 millimeter in diameter, but we can't see specific pathologies. So these are pictures that you might see under a microscope. So obviously, you have to take the brain or a piece of a brain, so it's not feasible in living people to do this. But if you take a person's brain and you slice it really thin and look at it under a microscope, you can see changes that are characteristic of specific diseases. We can't see these things on traditional MRI scans. So that's important to remember. So there's a size limitation on what we can see on the MRI. Now, when we talk specifically about Alzheimer's disease, this is a slide that I show a lot. This is a picture of Frau Auguste Dieter, who was the first patient that was studied by this fellow, Alois Alzheimer. And he described some of the salient pathologies in her brain. and at the time, this was felt to be a really interesting and unusual disease because she was so young. She was only 51 years old when her husband brought her to the hospital because he was unable to care for her. And she had experienced progressive decline, cognitive and functional decline, and then she died at the ripe old age of 55. And because she was so young, it was thought to be really unusual. So he studied her during life and then looked at her brain after death and saw these characteristic changes, these amyloid plaques, which are these accumulations of abnormal proteins that have gotten sticky and accumulated inside the brain. This is not something that you normally see in a healthy brain. And then these sort of triangular pyramidal shaped things, which are actually brain cells. These are neurons that have accumulated another abnormal protein, something called tau, and those have deposited inside the brain cells in something called neurofibrillary tangles. And so these two changes were recognized well over 100 years ago by Alois Alzheimer, and then they've been studied ever since. And one of the things that we figured out is what are the proteins that comprise these plaques and tangles. So the main protein associated with these plaques is something called amyloid or amyloid beta. And the main protein that accumulates in these tangles is a protein called tau. And one of the things that we've figured out over time is we've figured out how to measure these proteins in the cerebrospinal fluid. So many of our patients that we see, especially those with mild cognitive impairment, we may do a spinal tap. And this is a screen grab out of a video of somebody getting a spinal tap. And this thankfully covered butt here is my butt. And this is Dr. Hales, Chad Hales, collecting my spinal fluid here. And the reason we collect this spinal fluid is because this fluid is in direct contact with our brains, we can measure levels of these amyloid and tau proteins. And normally the levels of the amyloid protein is fairly high and levels of the tau protein are fairly low. But in somebody who has Alzheimer's pathology, the process is flipped. And we think that's because the amyloid protein is depositing inside the brain, and so there's less of it free to float around in the spinal fluid. And then the tau protein is normally trapped inside of the brain cells, inside the neurons. But when the brain cells get injured or die, the tau protein can be spilled out, and so you can measure more of this tau protein in the cerebrospinal fluid. And the way that we've been using this for many, many years now is because we know that normal individuals, healthy individuals without Alzheimer's disease normally have higher levels of amyloid and lower levels of tau, whereas patients with Alzheimer's disease have higher levels of tau and lower levels of amyloid. We can use the levels of these proteins to discriminate between control and AD. And where this was really important for many years and still is important for prognostic purposes is predicting what's going to happen in somebody with mild cognitive impairment. So remember, mild cognitive impairment is just a description of symptoms. And it makes a big difference what's causing that mild cognitive impairment. So if we look at people who have mild cognitive impairment, and everybody has mild cognitive impairment at baseline, at time 0 here. And then we look at what happens to people who have mild cognitive impairment with an Alzheimer's spinal fluid profile versus those who have mild cognitive impairment with a normal spinal fluid profile. And the people who have an Alzheimer's spinal fluid profile is represented by this red line. And what that red line indicates is that somebody who has mild cognitive impairment and has spinal fluid that looks like Alzheimer's disease over the course of the next 4 to 5 years will show progression from MCI to mild dementia. So it happens, at different rates at different individuals. But what this is telling us is if you have mild cognitive impairment when I test it, then during the course of the next 4 to 5 years, there is almost certain to be some degree of progression. And so this was very important for prognostic and planning purposes so that, while you are functioning at a very high level, you could put contingency plans in place to make sure you're safeguarding things and your wishes are known and everything else. The flip side of this is also important, though, because if you have mild cognitive impairment and I do the spinal fluid testing and your spinal fluid is normal, the likelihood of you progressing from MCI to mild dementia over the next 5 years is less than 10%. So for prognostic purposes, this was very, very important. And so we've been doing spinal fluid testing in MCI patients for many years, even before the current treatments have come along, which I'll talk about towards the end of the presentation. So what about these other non-Alzheimer's disease conditions? How do we know what it is? So what am I doing when I'm seeing and evaluating a patient in my clinic? Well, the first thing that we do is we collect information, and we're collecting information not just from the patient, but from somebody that knows the patient, because sometimes with people who have cognitive decline, they may have difficulty relating all of the details accurately. Most of the time, before I even get the patient, their primary care doctor has done some basic blood tests and other routine evaluations so that we can rule out certain things like thyroid problems or nutritional deficiencies. And then we'll look at something like an MRI scan to see if there are any structural changes. So for example, it's not common, but we might see somebody who shows up with a tumor that's affecting their brain function. Vascular disease, stroke, and vascular-related damage is something that we can see on MRI scans. So we're looking for any clues that are structurally abnormalities on the MRI scan that may help clue us in. And then the cognitive testing that I mentioned that everybody enjoys so much, evaluating your abilities in terms of memory and concentration, things like that, to see whether there's evidence of decline or impairment. And then it's really based on some ancillary tests, including the spinal fluid testing, but largely based on clinical features that we make these diagnoses. I put depression up here because we always consider depression. In our clinic, depression is not that often a primary cause, but we worry about depression because even if it's not the primary cause for cognitive decline, untreated depression can aggravate the cognitive and functional decline. And if we treat the depression, patients may do better, even though we can't do anything necessarily about the underlying degenerative brain disease like Alzheimer's or Lewy body or whatever. But it's really based on clinical features that we discriminate between these conditions. And so it's a pattern recognition thing that we all do as human beings. We use pattern recognition all the time to recognize what we're seeing or hearing or tasting or touching. And in the clinical history, there's a lot of overlap. So people may have difficulties with different activities that are similar across the Alzheimer's disease or Lewy body or frontotemporal or anything else, but there are certain features that may be more characteristic. So an Alzheimer's patient with primarily short-term memory may be very repetitive, and that may be a very prominent symptom. Patients who have frontotemporal dementias, their clinical history may be dominated by unusual behaviors. Somebody who has PSP, another cause, may have their initial sort of prominent reports may be mobility problems or falls. Lewy body patients may have a long history of something called REM behavior disorder, which is not typical in these other conditions. And so based on prominent historical features, we may be clued into one or another condition. But keep in mind, there's a lot of overlap, and you'll see that when I go over a couple of cases with you. We also, a lot when I'm examining you, I'm often testing, moving your hands or arms, or seeing how fast you move your fingers or things like that. And I'm doing that because there are some changes in motor function that may be associated with certain conditions. PSP is a really great example of that because in progressive supranuclear palsy, one of the really strong hallmark features of that is abnormalities in your eye movement. So if I say, follow my finger, and I look at where people's eyes are moving or how they're moving, that may give me a very strong clue that this may be PSP. And then stiffness in sort of movement resistance to movement, spontaneous resistance is something that we might see some Parkinson's-like features and then other overlapping features. In Alzheimer's patients, usually there are no specific motor features, at least early on in the course of disease. And then there are other patterns of cognitive or neuropsychiatric features. Lewy body patients may experience vivid visual hallucinations. I mentioned the behavioral features being very prominent in certain types of frontotemporal dementia. And rather than memory impairment, PSP patients may have more executive dysfunction, whereas on cognitive testing, the Alzheimer's patients will very often have a typical impairment in short-term recall. So there are a couple of patients that I want to just discuss. So this is a case report of one of my patients from a number of years ago. He's a 76-year-old male retired mechanic who had a long history of doing some dream enactment, acting out dreams at night, kind of thrashing around, fighting with people during his sleep. During the last couple of years, he'd become more forgetful of recent events. He was getting lost while he was driving. And more recently, he developed visual hallucinations. So he was seeing these people in his home, often at night. Initially, this wasn't very disturbing. It was a man and a woman. But the large man, especially, that he was seeing was becoming increasingly threatening and was showing up in his visual hallucinations with a large knife. He also had some mild Parkinson's-like features, some stiffness on his movements and slowness in movement. So some of these things that I mentioned, the visual hallucinations and the dream enactment behavior, as well as some of the Parkinsonian features, are highly characteristic clinical features of somebody with Lewy body disease. And Lewy bodies are something that were described initially in Parkinson's disease. So this is a part of a human brain cut near the base of the brain at an area called the midbrain. And this dark patch that runs right through here that you can see with the naked eye, this is an area of the brain called the substantia nigra. And this is the substantia nigra in a patient with Parkinson's disease. And you see that brown patch is really gone. And that brown patch is created by a pigment that's found in these cells that are in this part of the brain that are damaged and lost in Parkinson's patients. And in those brain cells, the first pathology that was really identified with Parkinson's disease were these Lewy bodies. So the brown pigment is this melanin, but these pink blobs here are Lewy bodies, and we know now that that is an aggregated deposit in these brain cells of something called alpha-synuclein. And in patients with Lewy body dementia, with the characteristic hallucinations and other features, those Lewy bodies are not just restricted to that area in the midbrain, but they accumulate across larger areas of the cortex. And you can see those when you stain for these synuclein deposits, and you can see those in brain cells and in processes of brain cells throughout the brain. Again, this is not something that we can see on traditional scans, but this is what the pathology that is typically associated with patients who have Lewy body dementia. The next person is a 77-year-old retired businessman, and he also was having a history of memory loss. So again, overlapping with what we might hear in an Alzheimer's patient with progressive memory loss. But he also had really prominent and peculiar behavioral changes. He became obsessed with working out at the gym, specifically with boxing. He owned multiple firearms and was obsessed with skeet shooting, and he was convinced that he could be an Olympic competitor at skeet shooting. And he frighteningly was traveling everywhere with handguns in his car. His wife moved out because she was afraid. He had no insight into what was going on. He did have profound memory loss. He was unable to recognize pictures of the president, Muhammad Ali. And then he had, and he was, again, very repetitive. The whole visit, he was repeating these stories about his boxing, his skeet shooting, driving fast cars on Georgia 400. So a lot of cognitive features, but these very prominent behavioral abnormalities. And on his MRI scan, we think that this one here is a control MRI scan. It happens to be my MRI scan. And I'm claiming that that's a normal MRI scan of the brain. And in my patient, what you're seeing here, you see that you can tell that there's some differences in the appearance of the brain here compared to over here. And what we're seeing here is really profound atrophy or loss of tissue in this specific area of the brain and the temporal lobe. And it's very profound. This is more than what we would typically see in a patient with Alzheimer's disease. But this is also a part of the brain that has an important role in memory, accounting perhaps for his very profound memory problems. But the forward part of this part of the brain can also be very important in regulating behavior and emotion. And so this is a patient who had frontotemporal dementia. And frontotemporal dementia is a fascinating and complicated disease. And it's one of the hallmarks of it is that it affects focal areas, either one side or focal areas of the brain, instead of more global or symmetric involvement. And depending on where the specific degeneration is occurring, the symptoms may be very different. So if there's involvement of the left frontal areas of the brain over here, you may see somebody who has progressive language difficulty, something that we call primary progressive aphasia. And then people who have, like the patient that I just described to you, who has damage in the anterior front part of the temporal lobe or in the right frontal lobe, those individuals may have more of a social abnormalities and behavioral abnormalities. And just like with Lewy body dementia, the frontotemporal dementias are associated with specific microscopic pathologies, but it's complicated because, in fact, we talk about frontotemporal dementia like it's a single disease, but they have highly variable clinical features, but they also have multiple different pathologies. So when we look at somebody with frontotemporal dementias, we may see different abnormal protein accumulations. This is TDP43. This is accumulation of tau. And so the pathology is variable. It's a very complex and interesting disease. It often will affect patients who are younger as well. The patient I just described to you was older in his mid-late 70s, but frontotemporal dementia patients are often significantly younger and maybe in their 50s or 60s more commonly than Alzheimer's patients. So I'm going to switch gears a little bit because there have been some really important developments in recent years and even months. And that is the first emergence of something called disease-modifying therapies. And this is important because so this is the same graph that I showed you before. And when people have degenerative dementias that get progressively worse over time, the problem is not here when people have mild cognitive impairment or very mild dementia. The problem is over a period of 6, 8, 10, 12, 15 years, the symptoms progress. And when they progress to later stages, this is where there's greater dependency and a real deterioration in quality of life. But also remember that most of our patients tend to be older when they develop these problems. So typically people in their 70s and 80s. And so the idea with disease-modifying therapies is if we can implement treatments that will slow the progression of disease and stretch that out, what that means is you have to live a lot longer to get to these late, terrible stages of disease. And so I don't think anybody has argued with me when I've said, you know, you ain't getting out of this thing alive. ain't none of us getting out of this thing alive. And the point of these disease-modifying therapies is if we can slow things down, and you drop dead of a heart attack or you get run over by a bus, while you may be losing some memory abilities and maybe declining some, but you're still functioning at a high enough level to enjoy time with your friends and family and have a decent quality of life when you die. I've yet to have anybody object and say, no, I want to keep living until I can get to the terrible late stages of dementia. And so this is a major advance, and I want to tell you about what's happening there. And then I also want you to realize that it's a first step. It's not a last step. It's a first step, because if we start slowing progression and give people a better chance of avoiding those terrible late stages of dementia, we just need to keep pushing the envelope so that we can start delaying the development of disease and then eventually preventing the development of disease altogether. So this is a picture of President Obama signing the National Alzheimer's Plan Act in 2011. And there were several different aspects of the plan's goals, but a primary one was to develop treatments to prevent or effectively treat Alzheimer's disease and related dementias by 2025. So that was a pretty ambitious goal. In 2011, there was nothing, and everything that we had done up to that point had failed. But we've had some success, and the reason that we've had success is, and right now I'm talking specifically about Alzheimer's disease because that's where we've made the most progress. But the same concepts apply to these other diseases, and so I think that there is an opportunity here, not just to advanced Alzheimer's disease, but other dementias as well. But one of the things that we've come to understand deeply about Alzheimer's disease is that it's a chronic disease. So chronic disease like heart disease, cancer, those are diseases that start and then progress slowly over time. So if you have heart disease, and specifically coronary atherosclerotic heart disease, what we're talking about is a gradual buildup of plaques in your coronary arteries and your heart's blood vessels that obstructs the normal flow of blood. And then if it reaches a critical stage of blockage of that blood flow, then your heart muscle is not getting enough blood and oxygen, and you have a heart attack. But this happens over a period of many years and decades. And so what cardiologists have been doing for decades now is trying to prevent this with great success, and using things like statins and controlling blood pressure and diabetes to prevent heart disease. Well, Alzheimer's disease is no different. These plaques and tangles we talked about, they're accumulating inside the brain for 10 to 20 years before somebody reaches the stage of mild cognitive impairment and progressive dementia. So this line represents the worsening of symptoms. These lines represent the accumulation of pathology 10 to 20 years before any symptoms are recognized. So this is a really, really important concept. I'm not going to have opportunity to talk too much about what we're doing down here. But the advances have come because we've recognized that this is an important aspect of Alzheimer's disease, that it may make a big difference where in the course of disease you initiate treatments. These are images. These are now something called a PET scan images, amyloid PET scan. And so what you're seeing across the top are 5 different patients who have Alzheimer's disease. And what the red indicates, the warm colors indicate areas where there's a deposition or accumulation of amyloid plaques. So we can use a special tracer that we inject into the body that gets into the brain, and it will stick where there's amyloid plaques. And that's what we're seeing here. And these are images from people who are involved in a clinical trial of a drug that is targeting this amyloid protein, and designed to eliminate the amyloid protein. And this is what these 5 individuals, what their brains look like at 1 year and 2 years after treatment. And if we focus in on just this one patient, what you're seeing is all of this amyloid that's accumulated. And then after 1 and 2 years of treatment with this drug, the amyloid is essentially gone. What we're looking at here, the remaining red and yellow here is just background staining. And all this amyloid that was in this person's brain is cleared away. And this is something that that we've known we can do. In fact, these images are taken from individuals who are in a clinical trial of an anti-amyloid drug that failed. It did not provide clinical benefit. And I'll explain what that's about here in a minute. The first drug that actually got FDA approval was a drug called aducanumab, and this was something that happened several years ago now, and there was a lot of controversy, and it's instructive about what we're doing with these drugs and understanding these newer drugs, and so I want to just walk through this story for a minute. So these are two different results from two different trials of this drug, aducanumab. And what we're looking at here is the plot of the amyloid PET. So how much amyloid was in these people's brains. And these black lines are the people who were treated with placebo. And these blue lines are people who are treated with aducanumab for 1.5 years. And what you see is this tremendous elimination of amyloid from these people's brains. And that was in both of those studies. And in one of these studies, the people who were treated with aducanumab had significant slowing. So this now higher on this graph represents worse clinical function, worse cognitive function. And people who were treated with aducanumab for 18 months in this trial showed significant benefit, 20% slowing of their cognitive decline. Problem was, in the second study, there was no difference between people who were on placebo and people who were on the drug. I know this line is below the placebo line, but this was not statistically significant. So there was no significant difference between placebo and treated individuals. However, the FDA decided, well, there's a lot of demand for new treatments, and so we're going to approve this drug based on something called accelerated approval. And what this process is it was designed back in the days of HIV, when there was no effective treatment for HIV/AIDS. And so this process was implemented so that we could accelerate the availability of anti-HIV drugs to patients who are otherwise going to die. And so what the idea was if you had a lab test that would predict who's going to respond. So in the case of HIV, being able to measure how much virus was in somebody's body, if your drug reduced the amount of virus in somebody's body, you could predict that was going to be beneficial to that patient. And what FDA said was, if you can show that your drug removes amyloid, we're going to accept that as a substitute for clinical benefit, and we're going to give you accelerated approval. And they did this in January of 2021. But remember, the evidence for clinical benefit to the patient was very shaky, and there were other drugs that had been tested to remove amyloid that didn't show any benefit. And so that was Medicare, that was FDA's decision, but Medicare came along and said, yeah, not so fast. There's not enough evidence that this drug actually benefits patients, so we're not going to cover it. However, they also said that if a drug demonstrates the ability to remove this amyloid and show clinical benefit to the patient, we'll start covering that drug. And they said that, and in late 2022, the drug study with lecanemab was published, and this on the left-hand side is again the PET scan. So people who were on placebo had no change in how much amyloid their PET scan showed. People who were treated with lecanemab had dramatic elimination, but they also very consistently had a 25 to 30% slowing of cognitive decline, and that was consistent across multiple measures. And so based on this evidence of clinical benefit, along with the clear evidence of amyloid removal, FDA gave full drug approval for lecanemab in July of 2023, and Medicare turned around and said the very same day that we will cover this drug. So this is a major advance, but it's not something that's appropriate for everybody. So we should only be treating patients who have a specific diagnosis of underlying Alzheimer's disease. And so it's we have to know based on either their spinal fluid or an amyloid PET scan that they have amyloid pathology with Alzheimer's disease. We know that if we treat patients who are in later stages of dementia, they don't benefit clinically. So what I showed you with in the PET scan, removing the amyloid in those people who did not benefit from a drug that was pulled from testing was because they were too far along in the course of disease. But if you treat patients in very early stages, they're the ones who appear likely to benefit. And we also have to take certain things into considerations for safety, something called ARIA. I'm not going to go into it in detail, but I'm going to show you what ARIA looks like. And then there's some special concerns with people who are on blood thinners or who have a specific ApoE genetic makeup, again, because of safety concerns. And so those safety concerns, so ARIA stands for amyloid-related imaging abnormalities, and it could come in a couple of forms. So this is an MRI from one of my patients who doesn't have any ARIA here, but this little black spot down here is an area of bleeding, of microscopic bleeding that was present in this patient's brain before there was any treatment. And so this is something that we see, but if there's too many of these microhemorrhages, if there's more than 4 of these, we think the risk of having more bleeding or swelling in the brain is too high. And so we won't put those patients on lecanemab. This is a picture of my patient a month after starting lecanemab, and we start seeing this area of swelling. This little white patch here is an area of swelling. There was no symptoms, and she was feeling fine. And so we continued to treat. And then 1 month later, there was a lot more swelling, and now there are also several areas of new bleeding or microhemorrhages. And this is quite common. This is something that we see in 20 to 30% of patients who are treated with the drug. Most of the time, it's just imaging findings without symptoms, and they can be safely managed. But if it starts to get more severe or people start to have symptoms, that gets a little bit more frightening, and we have to pause or sometimes stop treatment altogether. Because while overall the risk of something bad happening in the trials was pretty low, probably less than 1%, 3 people died in the course of the clinical trial. So this is something that we take very seriously. It's an important advance, but we have to be cautious in how we use these drugs. And then another really important advance, I'm going to spend just a couple of minutes on this, is you may have heard about these blood tests are coming along. So there are several different blood tests, including a couple that show real promise for being able to diagnose the presence of Alzheimer's changes in the brain without having to do a spinal tap or an expensive PET scan. And so these things are coming. They're not quite ready for prime time yet. Both of these publications were within the past 6 months, I think. And so there's a lot of work that still has to be done to establish their clinical utility. But I think this is going to be an important advance, among other things, to advance the timeliness of diagnosis. So I already said that those drugs that are coming along right now are only going to be effective in patients in very early stages of disease. And so if people are getting their diagnosis, but it's taking 3 or 4 or 5 years to get diagnosed, you may now be outside of that window of benefiting. And we also know that people benefit more the earlier we start these medications. So one of the places where I think these new blood tests are going to come into play is to expedite the evaluation and diagnosis of patients early on. So right now, this is a long drawn-out process that goes from recognizing symptoms by patients or family, your PCP and non-specialist, waiting to get an appointment in the stupid cognitive neurology clinic. I've been waiting for 8 months, finally getting an evaluation and diagnosis and maybe treatment. And so I think what's going to happen as these blood tests are improved and established, I think they're potentially going to expedite the initial assessment, and they may ultimately be able to replace spinal fluid testing or PET scans once we're comfortable that they're accurate enough to make that diagnosis and serve as a replacement. So I think there are going to be really important advances in this area in the next couple of years. And then lastly, one of the things that I don't know if any of you who are on or participating in the Cognitive Empowerment Program, but the Cognitive Empowerment Program is all about lifestyles and lifestyle interventions. And this is because we think that we can do a lot of dementia prevention. And this is some data that was published by the Lancet Commission. And what they reported was in early life, before the age of 45, improving educational access can reduce late life dementia by 7%. During midlife, between 45 and 65, treating hearing loss, avoiding traumatic brain injury, managing hypertension, obesity, avoiding excessive alcohol use, all of those are able to reduce late life dementia risk during midlife. And then in late life, after age 65, not smoking, managing depression and social isolation, avoiding inactivity. You can't really do a whole lot about the air pollution, but also diabetes. Managing all of those conditions and reducing those risks can overall reduce the risk of late life dementia by 40%. So we could prevent 40% of all dementias with lifestyle interventions through the lifespan. And we're focusing on that in the Cognitive Empowerment Program because we also believe that those lifestyle interventions can help delay and slow the progression of degenerative diseases. So very important non-pharmacologic things that we can all be doing to help reduce the risk of late life cognitive decline. So with that, I'm going to stop. I left a few minutes. I don't know if I left enough time. I know you guys wanted me to leave more time, but I had a lot of stuff to cover.
You covered it so well, Dr. Law. That was great. Thank you so much. And I always love your sense of humor and your approach to this. We don't have any questions in the Q&A section. If you do have questions, please type them into the Q&A section. And you can find, if you're on a computer, you can find the Q&A down at the bottom of your screen right next to participants. If you're on an iPad or an iPhone, I believe it'll be near the top.
Mm-hmm. Yeah, I did see an alert that someone had raised a hand, but we unfortunately cannot unmute you. So we need you to put your question or comment in Q&A.
So can you speak to the newest drug that is in clinical trials? So I think that the participant may be asking about donanemab, which is another anti-amyloid antibody. And that is one that's out of clinical trials now. It's being reviewed by the FDA. We were anticipating that the FDA would have a decision on that drug in March, but it's been delayed, and they're looking for additional input from an advisory committee. And the reason for that is that and it's a little technical, the way the clinical trial was set up was very complicated in that case. And so I think FDA is really struggling with the labeling guidelines, how to instruct physicians on how to prescribe that drug. And so that's going to be interesting. There's interest in that drug because there's some evidence that the drug removes amyloid even more rapidly than the lecanemab. And also, lecanemab is infused every 2 weeks, whereas the donanemab is infused every 4 weeks, so half as frequent dosing. But there's sort of upsides and downsides. The frequency of ARIA, the complication rate, was higher in the donanemab trial. And so that's a downside. But the complication for me, trying to figure out how I'm going to prescribe donanemab is the biggest challenge, because the way they designed that trial was very, very complicated. Very similar drug, also very promising. And so I think there are going to be others that come into this space. There's another question about when will the blood tests be ready for general use? So last summer, there's a number of different blood tests. And last summer, Quest Labs actually started doing direct-to-consumer marketing. So they were marketing to the general population, and I think they were selling it for something not crazy, like 300 or 350 bucks, that you could just go to a Quest lab and request the test, and they would do the Alzheimer's test for you. That was really upsetting because their test had never been published. I had zero data on the accuracy or quality of their test. And so I was happy to see a month ago, in March, they pulled that test from direct to consumer access, and it can still be ordered by a physician, but at least they're not doing direct to consumer marketing of that. I'm not using that test because I have no idea if that test is any good. The other question about when will these tests be ready for broad use is about coverage, because the spinal fluid test is covered. The PET scans may be covered under certain circumstances. The blood tests are not being covered. They don't have sort of standard FDA approval yet, any of them. And so they may be quite expensive, and we're still getting comfortable. I would say that, and also the primary care docs who may benefit the most from the availability of blood tests, right now, most of them want nothing to do with it. If they do an Alzheimer's blood test on one of their patients and they get a result and it's a positive result, they're kind of terrified about what to do with that, how to manage that. So we're working with our primary care colleagues, trying to develop a system to use those tests most effectively. I think it'll be a couple of years. It'll be pretty quick. I think in a couple of years, we'll have enough evidence to make me comfortable that I may be able to substitute one or another of these blood tests for spinal fluid testing or PET scans. And so that may happen within the next couple of years. But we still have a lot of work to do to figure out how to use those tests in conjunction with our other tools. What's the link between hearing loss and dementia? Man, that's a great question. The short answer is I'm not sure, but the link is very strong. You can, if you just think about this logically, if you have untreated hearing loss in your 40s or 50s, you're not getting the information in as efficiently, that's going to degrade your ability to interact with other people. You may miss out on things. It may reduce the overall level of engagement and stimulation. And those things we think are important lifelong elements to maintaining your brain's resiliency against age and disease-associated changes. So that's sort of an obvious one, especially since the linkages that they uncovered from the literature review was in middle age, not in late life. But our ENT folks are also fascinated because there's some really interesting parallels between sensory neural hearing loss, which is the primary type of hearing loss that we have as we age. And there may be some mechanistic links between degenerative changes that are responsible for the sensory neural hearing loss that may also be involved in producing cognitive decline and dementia. So it's a really important question. We don't have a clear answer to that. And another important question, if one is not suitable for lecanemab, what's the next course? Yeah, and this is something that is a source of frustration and for a lot of people, for us too. Because, if I want to treat a patient but I don't think that person should be treated because of safety concerns, what do we do? So there are a couple of things. There are some other drugs that are being tested now that aren't clinically approved yet, but there are other drugs that target things like the tau protein, or that there's a drug that's in development that is inhibiting an enzyme that's responsible for modifying the amyloid protein. So these other mechanisms that may not be associated with the same ARIA, the swelling or bleeding, as lecanemab and other anti-amyloid monoclonal antibodies. So right now, the options are the older available drugs that have been around for a long time, and then clinical trials that are one of the things that I encourage people to do. If you have MCI, and if you are close enough, or if you're further away, I want you to access either the in-person full Monty cognitive empowerment program or the remote programming to take advantage of those lifestyle interventions, which I know are going to be beneficial, and give people the opportunity to participate in other clinical trials that may not have an exclusion for the RE or microhemorrhages or like those things.
Dr. Law, thank you so much for your presentation. It is absolutely incredible. As usual, we have more questions than we have time for. I really encourage folks to talk with their providers with some of these other questions. I'm sorry we didn't have time for all of your questions today. But thank you, Dr. Law, and I hope everyone will come back next month, the second Wednesday of the month. We will be talking about hiring home care in the home and things to be thinking about with that. And we have some great speakers for that. So thank you very much.
Bye all.
Thank you, Dr. Law.
Bye.